invited here today. It's a nightmare following these two speakers that we just heard from prior to me. Nigel and fellows of BASEM, thank you again for the invitation, and hopefully I'll be able to shed some light from what we see, differentiation of athletes' hearts from cardiomyopathies. Athletes are at the sort of height of physical prowess, and we would expect the external features of an athlete to mirror internally as well. And we'd expect our hearts to have the same degree of high physical performance. I'm lucky to have this photograph here of Nigel as a younger individual. I'm sure it's you, Nigel. But more seriously, Michael's run through all of this, and we really don't want to see events such as this with athletes collapsing on the pitch. And again, as has been mentioned, the survival from cardiac arrest after 10 minutes, it really is quite abysmal. So we would aim to see these athletes beforehand and screen these athletes to reduce the risk of sudden cardiac death. And as Sandra has alluded to, one of the commonest causes seen at post-mortem is hypertrophic cardiomyopathy. This is the Italian data, which showed around 36% was due to hypertrophic cardiomyopathy, another 10% may well have been, and arrhythmogenic right ventricular cardiomyopathy, which we'll talk about in a moment, around 4%. Of course, there are other causes here as well, and the big ones such as clearly anomalies at 17% are difficult to diagnose beforehand. Now, you compare that with the Italian data, and again, as you've seen on the excellent presentations before, you have had a significant reduction in the risk of sudden cardiac death, especially with the cardiomyopathies, with hypertrophic cardiomyopathy, especially, with an increase in ARVC as an overall percentage, but the overall proportion of deaths are a lot less. And that's, again, as Sandra has talked about, really comes about by the reduction in sudden cardiac deaths. And again, not wishing to sort of go over data we've talked about already, that's unscreened athletes, and then the reduction 3.6 to 0.4 per 100,000 per year over this 20-year period. But importantly, there's a death from the cardiomyopathies as well. So in Italy, there's a reduction in cardiomyopathic death with the screening program. And again, we won't talk about the not very good incidence today. So we've seen around 89 to 90% reduction in sudden cardiac deaths over this period. And again, I'm not wishing to go over stuff that we talked about already, but this is prevalence where I'll be talking about. The original work that was done in Italy, that did show that the group 1 changes are seen very commonly in athletes and are not usually associated with cardiac abnormalities. But the group 2 changes, including the 2A changes that have been discussed, these are associated often with abnormalities that can be seen in hypertrophic cardiomyopathy and arrhythmogenic right ventricular cardiomyopathy. So in those cases, we would recommend some further evaluation for those other changes. But again, things have moved on. I'm not going to go over this, except to again mention the fact that this convex dome death elevation seen in athletes when the Seattle criteria was published. We just take one of these. You can see that there are marked changes on the athlete's ECG, but in the black athletes, when we see these changes in the black athletes with this dome death elevation with 2-way reversion extending to V4, but usually not further, may well be a normal variant. And in particular, there are no 2-way changes in the lateral or inferior leads or the high lateral leads. So this may well be viewed as a normal variant in the black athletes, not so much in normal in the white athletes. And again, this is prevalence what I've been talking about, and again, Sandra has stressed all of this, the new international consensus standard that will be coming out, again, just sort of shows these normal ECG changes, and again, showing the black changes on our ECG, 2-way inversion V1 to V3, the abnormal changes, especially ST segment depression, Q waves, etc. And if you have 2 of these ECG changes, this may well be a normal, may well not be a normal variant, but in isolation may well be. So that's a background, which has again been covered. What we need to do is differentiate between athletes and who have a physiological change and a cardiac adaptation to their sport, as opposed to those that have changes which may well be due to a cardiomyopathy. And this, again, as we mentioned, can be related to the sex of the athlete. Males may well have greater changes in the dimensions of their heart and also the thickness, the age of the athlete, ethnicity, you've seen with black athletes, body size, the amount of training that the athlete may well do, and the type of sport and the level of sport. We've seen that in endurance runners who may well have enlarged cardiac chambers. So if you actually compare the differences, a lot of the changes that we see in athletes are normal. The thickened heart muscle, the enlarged chambers, all four chambers may well be enlarged. These may well be normal. But what is physiological and what is pathological? 80% of black athletes may have a wall thickness 13 to 60 millimetres and even above that, versus 4% of whites, which may well be physiological. But equally, wall thicknesses of 13 to 60 millimetres may be seen in 10 to 15% of hypertrophic cardiomyopathy patients. So you're now looking at a group which has a grey zone which could be in either group. Are you playing this athlete who's absolutely fine and fit to play without any significant risk, or are you actually missing an athlete who has hypertrophic cardiomyopathy? So if you just go over the cardiomyopathies, I'm not going to talk about all of these cardiomyopathies, I'm going to limit it really to the top three, and if we have time, maybe just talk a little bit about LV non-compaction. So for hypertrophic cardiomyopathy, many of these are inherited diseases affecting scapulae proteins or desmosomes. Hypertrophic cardiomyopathy, hypertrophic, as expected, would be thickening at different parts of the heart muscle. May well not just be the asymmetrical septal hypertrophy, may well be apical, maybe right ventricular, maybe concentric, many features and different types of hypertrophic cardiomyopathy. Dilated cardiomyopathy may well have filling of the left ventricle and poor left ventricular function, both radial function, where we measure ejection fraction going this way, or longitudinal function this way, which we'll talk about as well. May also affect the right ventricle as well, which can make it difficult in athletes, because athletes can have dilatation of both ventricles, and including the atrium as well. Arrhythmogenic right ventricular cardiomyopathy may well have fibrofatulous placement of the right ventricle, but also may well extend into the left ventricle as well. And may well have areas of what are called dyskinesis or akinesia, little areas that don't move, little aneurysms within predominantly the right ventricle may be seen, a high risk of sudden cardiac death. And LV non-compaction, well, this may well have non-compacted areas of the heart, which may well be mistaken for hypertrabeculation that you see in athletes. So there are different types of these cardiomyopathies which may well have an overlap with what is seen in athletes. So if you take the first one here, hypertrophic cardiomyopathy, this is defined as a presence of increased left ventricular wall thickness, which is not explained by other major conditions such as aortic stenosis or hypertension, etc. And again, athletes may well have thickening of the heart muscle, but not to this degree. This joint axis view here, you can see there's almost cavity obliteration here. There's so much significant thickening, concentric LVH here. And the septum here, you may well see other features of systolic anterior motion of the mitral valve and mitral regurgitation, outflow tract obstruction, crypts, etc. But basically, there's a lot of thickness of the heart muscle here. Now, we may well see ECG changes, and maybe particular changes on the ECG which point towards this being more hypertrophic cardiomyopathy rather than athletic. And in this case, for the people that look at one of these ECGs, these groups electrical T-wave inversions, well, as you've seen previously, the ST elevation with the T-wave inversion V1 to V4 in the black athletes, if you see these types of T-wave inversions, these deep symmetrical T-wave inversions, this is more worrying. This may well be a feature of apical hypertrophic cardiomyopathy. Also, there's some bilateral T-wave inversions here as well. So this would be an abnormal ECG for an athlete. And again, the differentiation really is between what is athletic and what is hypertrophic cardiomyopathy. So you may have these unusual patterns of LVH in hypertrophic cardiomyopathy. You may well have small left ventricular cavity versus a large left ventricular cavity in an athlete. They both may actually have left atrial enlargement. You may get these bizarre ECG patterns. We'll talk about left ventricular filling a bit later. Fitness as well. If you detrain an athlete, as you all know from the room, if you ask an athlete to detrain, he'll ask you, well, can I still go to the gym and cycle for 3 hours a day? You know, you actually got to detrain. We've actually shown in a study with myself and Sanjay and Greg White some years ago that you can get changes in 4 weeks. If you manage to detrain an athlete for 4 weeks, you may well have resolution. And I've had an athlete I saw yesterday in the cardiomyopathy clinic who had these changes, which has all but normalized part of a biphasic T-wave in V4 after detraining for 2 months. Does it still mean you've got HCM? I'm not sure, but you can get some massive resolution in ECG and also the echocardiographic changes as well. Also, there's a family history of HCM and you have abnormal ECG, it makes it more likely that the athlete actually has hypertrophic cardiomyopathy. Most of the athletes getting symptoms as well, and we can do CPEX testing out of the test. So this is a paper brought out by BSC, Dave Oxborough, and some of the panel here today. And this is a sort of minimum data set for cardiac screening. And this is a great document in the sense that it actually shows you where to sort of take some of your measurements and what to do next with trying to differentiate between physiological and pathological changes between athletes and those who suspect of cardiomyopathy. So if we take a thickness or wall thickness, so if it's over 12 millimeters or 14 millimeters in male and 13 millimeters in female black athletes, the next thing then is to look at left ventricular function. As I said before, there's different ways of looking at left ventricular function. You can look at the radial function, so-called ejection fraction, which may well be normal. In fact, supernormal, maybe 80-90% with a cavity obliteration. But in addition, you can look at the longitudinal function, how the heart moves in another direction. This is what the S-prime looks at. And also the filling of the heart as well, so-called E-prime. So we're looking at systolic longitudinal function and diastolic filling. And if these numbers are low, less than 9, it shows that the heart is impaired in some way as well. It's not actually filling very well. It's not moving very well in a different direction. And these are very, very sensitive. And if these are low, then it makes pathology more likely. If these are normal, it makes physiology more likely. But in addition to that, going to listen, take measurements to begin with, then look at these, the movements on a tissue Doppler. But in addition to that, you need to correlate that with ECG changes. You need to correlate it with symptoms. Is the athlete actually blacking out? It's a pretty high-risk symptom. Is there family history of sudden cardiac death? Is there family history of HCM? And it was negative for all of those, and this is all normal. It may well be this is all physiological. Otherwise, if it is pathology, then obviously you have to screen further. So I'm just going to take you through a couple of cases here. This is a 41-year-old black elite footballer, routine cardiac screening, asymptomatic, no family history. ECG. Well, you've just seen it recently. Normal or abnormal? We've got one abnormal. Normal. Okay. So I would say this is a normal ECG for a black athlete in the sense that there's bone dust elevation, the two-way inversion, V1 to V4. No other two-way inversion elsewhere, no Q waves, etc. So I would call this likely to be a normal ECG in a black athlete. In fact, on detraining, if you just happen to detrain over the close season, ECG normalised anyway. So there is a change, a physiological change here. So that was normal. Didn't have to detrain, we just happened to. Okay, so that's normal, no further investigation required, except if he requires, if he's part of the first team, then he would require an echocardiogram as part of UEFA guidelines. Okay, 27-year-old black elite footballer, routine cardiac screening, asymptomatic, no family history, and I was asked to see him for a second opinion. I was actually sent the report from his notes rather than seeing him directly. Normal or abnormal? Right. Very abnormal. Right, okay. So we have some features which look different. These peaked and tall T-waves, which are normal, okay, commonly seen in white athletes, with these peaked and tall elevation, repolarization changes, LVH and voltage criteria, again, normal. So especially here, though, it is to a Q-wave, V1 and V2, so these deep T-wave inversions, biphasic here, deep T-wave inversions, and in the inferior leads as well. Again, from Michael's paper, this shows that this is commonly seen in some of these hypertrophic conditions, and less so in a normal black athlete. So yeah, I would agree, this looks as though it's abnormal. Normal cardiac exercise testing, normal 24-hour state, go on to have a cardiac MR, and we have the Don in the audience here of cardiac MR. And you'll say that the light's too bright to look at this, but what we can see here is we can actually see some apical cavity obliteration here, I think to a degree here, and it probably doesn't show very well. Actually, let's take the light exposure to the fraction, if you don't mind. There's actually some fibrosis here at the apex. Just get those lights down, fraction. There's some fibrosis here at the apex as well. I'm quite worried about this athlete. Okay, we've got an abnormal ECG, he's asymptomatic, but I'm still quite worried that there's some cavity obliteration here. I haven't seen any crypts or anything, but anyway, fibrosis there. And the measurements as well, wall thickness of 40 millimetres with the apical anterior segments, that's pretty significant, right? And what we felt here, again with this hyper enhancement here, we felt that this was quite significant. And again, we didn't see the athlete, just the centre of the pictures. And we would say that this is apical hypertrophic cardiomyopathy with fibrosis, with a risk of ventricular arrhythmias and a potential risk of sudden cardiac death. And we would recommend restriction from competitive sports, which we don't do very often. We don't restrict that many athletes. We would restrict. He's still playing. He's ignored us. Okay, so that's still pretty abnormal ECG. Okay, so dilated cardiomyopathies, as opposed to thickness of the heart muscle, let's talk now more about a dilated heart. This isn't an athlete. This is somebody in my standard general medical clinic who's got very poor left ventricular function here, biaxial enlargement, thin-walled on this side. There's more calculation on that side. But anyway, it's poor left ventricular function here, so radial function and longitudinal function would be quite significantly impaired here versus a normal non-dilated heart. So again, we have to differentiate between the physiology and the pathology of a dilated heart. So in a male, left ventricular diameter of 59 millimetres, or female 53 millimetres. Again, assess left ventricular function. And again, you can use ejection fraction here. If this is less than 55%, it makes it more likely to be pathological. Again, look at longitudinal function, not just ejection fraction. Look at longitudinal function, the filling and the S prime. And again, if these are less than 9, it makes it more likely this is pathology. Over 9 makes it more likely that this is physiology. The E over E prime, the left atrial pressure, this is greater than 12. Again, it's more likely this is pathology. And again, put this into context with ECG, there's widespread T-wave changes, symptoms, dizziness, blackouts, family history, etc. And again, if these are all negative and this is all normal, it's more likely this is physiology, and the dilated chambers of the heart may well be physiological rather than pathological. So let's take another case here. This is a 19-year-old Caucasian elite footballer, no family history of sudden cardiac death. He was diagnosed, I guess the second opinion, it was referred to me because they weren't sure when he had a virus, and then he was a little bit lethargic. Then had an echo, and the echo suggested he had this post-viral myocarditis and a dilated cardiomyopathy. Went on to have a cardiac MR, and that suggested this post-viral myocarditis. He was then treated with an ACE and a beta blocker, which is standard treatment for poor left ventricular function with dilated cardiomyopathy, and then became pre-syncopal. So then he became high risk. Now they're considering whether to put a defibrillator in this young footballer because they're wondering whether he's actually having ventricular arrhythmias. So this is his ECG, normal or abnormal. There's nothing overt here that's abnormal. There's no T-wave, no ST depression, no significant T-wave inversions, LVH voltage criteria, normal variance, no inverted P-wave. I mean, T-wave inversion 3 normal. So this is a normal ECG. Okay, we've got a normal ECG here. So the echocardiogram showed a large right and left heart, all 4 chambers. The ejection fraction was 50%. His tissue Doppler, the longitudinal function, was a little bit low. It was averaging about 7. So this is less than 9. He's making more weight here, okay? But then we exercised him, got his heart rate up by only 20 beats, from press-ups and sit-ups, redid all his measurements, and actually showed significant improvements. So his ejection fraction went over 60%, his tissue Doppler measurements went 12, 13, 14. So actually, these were bradycardic changes. These low values were due to him just being bradycardic. We increased it, and everything normalized. He did undergo a 24-hour Holter monitor, cardiac exercise testing, likely normally being pre-trained, and he was on a beta blocker and an ACE, and didn't feel too good. And then we repeated the cardiac MR. Sorry, again, can we just take the right hand fraction, please? Repeated the cardiac MR and compared it to the previous ones as well. Okay. And again, he has got dilated chambers, all 4 chambers appear to be dilated. But I'm not sure there's any significant abnormality here. I've got a normal from the front row here. So, again, the chambers were enlarged, his left ventricle was enlarged, his right ventricle was enlarged. Function around 55%. The gadolinium was negative, hyperenhancement as well, and our second cardiac MR was completely normal. We then went to have a look at the first cardiac MR when it was sent down to us, And again, we felt that was normal as well. In fact, we felt this was purely athletic heart. We stopped his ACE and his beats blood and returned to full training, symptoms went, and a few weeks later scored for our international team. So this is normal. Just because you've got a big heart, ejection fraction is low, doesn't mean your heart's abnormal. Okay, arrhythmogenic right ventricular cardiomyopathy. Okay, this is an inherited condition. This is probably the one that weighs most of the panel as one of the two conditions that we risk of missing, ARVC and coronary anomalies. Often, it is a family history of sudden cardiac death. Often there's exercise-induced sudden cardiac death. 82% have history of syncope, ECG changes, or ventricular arrhythmias. Up to 87% have two-way inversion beyond V1, but we've heard that may well be normal. V2 may be normal, but V3 onwards may well be one of these conditions, either HCM, ARVC, or another abnormality. So, again, look, it's five factory replacement of the right ventricle, may extend to the left ventricle, risk of ventricular arrhythmias. And on the cardiac MRs, you may well have dilatation of the right ventricle and aneurysms as well. The task force criteria has proposed that you have enlargement of different parts of the right ventricle, but we see that in athletes as well, so that's the worry. And a lot of these measurements that we see in athletes, the right ventricular outflow tract, the inflow, these are things that we see in athletes commonly. But the important thing to say is that you also must have an area of RV akinesia, an area of the right ventricle that doesn't move, or dyskinesia, moves slowly, with aneurysms as well. Not just the measurements in their own right. Again, so we have lots of measurements, the RV plaques views, the different views, the right ventricle and the left ventricle are getting larger together rather than just the right ventricle with ARVC. Different measurements here. So it's not just the measurements, but if we do have an athlete with a large right ventricle, slightly different algorithm, again, we look at right ventricular function, look to see that there is movement in the tricuspid annulus, and again, if there's good movement of that, if the RV fractional change, again, the longitudinal function of the right heart is all normal, and the subjective assessment that there isn't in the aneurysm or area that's not moving, then maybe this is more likely physiological, again, with normal ECG, family history, etc. If you have some of these changes in addition, with evidence of dyskinesia or akinesia, you're more wary, you're wondering whether you're going to miss an ARVC. Because these are four from the literature here. This one here, two-way inversion, V1, V2, V3, and even V4. This unfortunate 19-year-old died of ARVC. 29-year-old, again, two-way inversion, V1, V2, V3, and then V4, with ectopic beats. This is likely, this is a left bundle branch block morphology, ectopic beat, likely to be originating from the right ventricle. Wasn't then investigated and died. These are more difficult. I think the panel would agree that these are slightly more difficult. This one here, this is ARVC. This is not something that we would say is a definite ARVC. Would you agree? Anyway, suspicious. Unfortunately, went further investigation that they died. So, another case here. 18-year-old Caucasian elite rugby league player, no family history, asymptomatic. ECG, normal or abnormal? Normal. Grumbling normal? Loud normal? Heavily normal. Good, okay. Normal, okay, so nothing overtly abnormal here. Okay, so again, so we're seeing here the RV plaques view, seeing this enlarged right ventricle, left ventricle, seeing this enlargement here. We're seeing the outflow, RV outflow here, we're seeing RVOT1 here, again enlarged, the right ventricle big. Okay, the LV looks a little bit big as well, left ventricle. What we're focused on here is the apex of the right ventricle in this view. So we're now looking at the apex here. This doesn't seem to move as well as further down. And we're suspicious that this is arrhythmogenic right ventricular cardiomyopathy. Okay? But all the other measurements that we said in the algorithm were normal. So you now have an athlete who's asymptomatic, he's just come along for an echo, an ECG just to be screened. And we're now telling him he's got a potentially high-risk condition. He's going on to have cardiac MR. That's completely and utterly normal. And we've seen a few of these, and I think the panel would agree that we're starting to see cases like this. We're not sure about this. It's because the right ventricle wraps around the left ventricle. It's difficult to get the right cut. And this is actually a normal variant. Normal variant, no training or playing restrictions. He's gone back to playing, is absolutely fine. So, the differentiation here between the different conditions Hypertrophic cardiomyopathy, again, if you've got lots of symptoms, lots of ECG changes on the echo, these are things that really worry you, fibrosis and what have you. Athlete's heart, we've isolated LVH, we've got symmetrical LV and RV enlargement, normal function, and then there's crossover where we're not sure. Again, we have to try and work out which group of the chart we're going into. Then for dilated cardiomyopathies, again, you can have the large left ventricle, but it's whether you have other features of two versions of symptoms of family history, and whether there's improvement with exercise as well. I haven't talked about genetic testing, but if you are gene positive, then it obviously makes it more likely. But unfortunately, if you're gene positive as an athlete, then you can't play even if you haven't displayed the condition yet. So you don't often gene test athletes. ARVC, we talked about as well, T-wave changes on the ECG, radiation abnormalities, and other things such as VT on exercise testing or the Holter monitoring. But otherwise, these right ventricular dilatations are common finding that you see in athletes as well, but you don't have those areas that don't move. So, LV compaction, I'm just going to very, very quickly, because we're running out of time here. You can get lots of tuberculation in athletes, and it can look like LV non-compaction. This is a 20-year-old black athlete, he's a footballer, asymptomatic, no family history. This is an ECG, normal or abnormal? Horribly abnormal. Okay, apart from the LVH, usually LVH just looks a little bit too far, even though we don't really measure this. These two-way changes here, and also the two-way changes in theory as well, but it's not the nice looking ECG. And then went on to have, unfortunately these went wrong, but went on to have his echo removed. There's some stuff in here of LV non-compaction rather than hypertuberculation. And then went on to have his cardiac MR, and there were similar findings as well. And Rory's making that face, he says, I'm really not sure this may well be LV non-compaction, just another form of cardiomyopathy. So we're not sure which one it is, and it could be this condition, isolated left ventricular non-compaction, where you get these non-compacted areas again, highly arrhythmogenic. Tape was normal, exercise test was normal, the MR went halfway around the world, came back to us, and we were told that this is a potentially normal variant for African Caribbean. He's under annual review, allowed to fully compete. So, and the final slide. So the differentiation between athletes' hearts and cardiomyopathies can be difficult. The important thing is not to miss a cardiomyopathy or restrict an athlete who just happens to have physiological changes. The new ECG criteria will be very, very useful. This algorithm also is extremely useful at looking at the differentiation between the different groups. And Nigel will remember this picture from his time up in Liverpool. This is on the door at Liverpool. The stone has been set. These are Robbie Fowler, Michael Owen, Jamie Carragher, etc., as younger boys. Thank you very much.